So my topic is how to manage an expanding false lumen and thoracoabdominal dissections. So we are specifically going to focus on type B dissections. Now, just as an introduction, about 30% of acute type B dissections managed medically will require some form of repair. Now, the interesting thing is if you place a stent graft in acute and chronic dissections, about 90%, about 80 to 90% will remodel. So all you're doing is covering the entry tear. So we have to understand that the concept of dissections are very different than degenerative aneurysms. And if you have a proximal stent graft floating in a AAA and you leave the distal end open, the aneurysm just isn't going to go away. But in dissections, in 90%, it will. So it's important to understand that dissections are not aneurysms. They behave very differently. Now, my topic is there's 15% of the people who have persistent false lumen that continues to enlarge, how to manage these. So if you look at on this slide, the management of type B dissections, surgical management, patients do very poorly if you do open surgery for acute type Bs. Endovascular appears to do better than even medical management. So we are trying to focus a little bit on how to manage these patients endovascularly. Now, the whole concept of the false lumen continuing to enlarge depends on the entry and re-entry tear. You can see on these cartoons, if you have the dissection model where the entry and the re-entry point are just in the thoracic aorta, a thoracic stent graft, you know is going to seal this. However, in majority of the patients, the type B dissections does extend all the way distally. And depending on the location and the size of the entry tear, you can get continued false lumen perfusion. Now, unfortunately, these entry tears are quite complex. They tend to usually lie at the level of the left renal or the celiac or the SMA. So they do require pretty extensive endovascular techniques to treat them if there's continued expansion of the false lumen. In acute type B dissection, we treat them. We've shown this device before. We typically will use the left subclavian side branch device. We don't cover the subclavian anymore. Shown here is a typical example of a patient who came with a type B dissection. There was distal malperfusion from a collapsed true lumen. We have stented the patient with a subclavian side branch. You can see the follow-up CAT scan in 1 month. The false lumen has completely disappeared. Good flow into the true lumen of the aorta. In a chronic dissection, this patient was 5 years out. There was persistent enlargement of the false lumen. Interestingly, the patient just had a single entry and re-entry point in the descending thoracic aorta. Thoracic stent graft in this place solved the problem. Now, there are other techniques described to manage the false lumen, use of plugs and coils. In my experience, these typically don't work once you have a large false lumen. These only work in cases shown like in this example where the false lumen is very small, and coils simply tend to hide where the flow is in the false lumen. I use the Knickerbocker techniques just for type B dissection with a rupture because you do want to seal acutely. This technique involves placing a thoracic stent graft. I extend this typically all the way to just above the SMA. Then you use a non-compliant balloon, and you balloon and rupture the septum so you get a seal. So thoracic aorta at that point typically needs to be less than 4 centimeters. And this technique, again, doesn't prevent enlargement of the false lumen distal to the distal seal. So you can continue to have false lumen enlargement distal to the distal seals. Again, it doesn't completely solve the problem of false lumen enlargement in the visceral segment. So what you're going to focus on how to manage these distal re-entries. So Knickerbocker and coils will not help in these patients as you will not be able to completely exclude the re-entry and entry points in the visceral segment. So I'm going to show an example of a patient of mine. So I tend to stage these. So this patient in acute type B dissection, we have placed a proximal stent graft. And the majority of these people, the false lumen will disappear, and this patient has not. Just run through this one more time. You can see the proximal stent graft. We have 2 large entry tears, one in the descending thoracic aorta, another one in the visceral segment. You can see a large entry tear between the celiac and the SMA. There is also a large proximal entry tear just distal to the prior thoracic stent graft. So in these patients, despite the fact that the entire thoracoabdominal segment is enlarged, I don't dress them all at one time. We tend to stage them. That decreases your risk of paraplegia. So you place the initial stent graft. I wait about 6 months. I bring him back. That's a CAT scan at 6 months. At this point, we're going to extend to the level of the SMA. You can see a very tortuous descending thoracic aorta. We were able to track the stent graft through that. We had to pull it through and through wire to be able to track this. Mm-hmm. I typically will cover the celiac. I rarely see issues with that as long as you have a good gastroduodenal. So here we've extended just to the level of the SMA. So we've covered the celiac. This is a second stage repair. And in some patients, this suffices. Even though you have a distal re-entry tear, Remember, I told you that dissections don't behave like degenerative aneurysms, and this usually stops the growth of the false lumen. So I bring the patient back in 6 months, get another CAT scan. This just shows the AP view showing that we sealed the proximal reentry tear in the descending thoracic aorta. Repeat CAT scan shows that the thoracic segment now has completely thrombosed. Right, that's thrombosed, but you have this large reentry tear between the celiac and the SMA. So in this patient, we will use a single SMA fenestrator device. I would place a stent in the left renal. I've stopped making physician-modified devices other than the single SMA fenestration, which is already we have these as rupture devices. So we have single SMA fenestration devices. I don't modify these devices for the renals because the moment you deploy the first stent graft for the SMA fenestration, in dissection patients, the renal orifices will significantly move. So we tend to pre-stent them. In this case, the left renal comes off the false lumen, so I placed a stent. I have a stent inside the left renal extending across the false lumen. You can see the stent has been deployed. This is just to mark it so I can refenestrate using a laser into the left renal. That's the SMA fenestration. This is the full lateral view. So these are devices with a single SMA fenestration. So if you cannulate the SMA, we'll deploy a stent, fully open the device. Typically, I'll have 2 renal stents. In this patient, I did have a physician-modified hole for the right renal as the right renal was not involved in the dissection. I've cannulated the right renal. I'm going to place a covered stent extending into the thoracic stent graft. And then I have my tour guide catheter pointing towards the left renal. So typically, we will laser fenestrate that. I've actually moved away from physician-modified devices to laser fenestrating all my juxtarenal aneurysms. It tends to move much quicker. It's a lot simpler to do. So once you're able to fenestrate through the hole, I usually will use a coronary balloon dilated followed by a covered stent. And then we extend all the way to the iliac bifurcation. So this is my 3rd stage repair. First was proximal thoracic. Second was distal thoracic to the SMA. Third was covering the visceral segment all the way to the iliac bifurcation. Now you can see the completion angiogram, good flow in the renals. And so typically this is how we manage the false lumen and thoracoabdominal segments. You can see a coverage now all the way from the left subclavian. Most of the times now will come from the left common carotid with the subclavian side branch. We'll have a fenestration for the SMA, both renals, and the graft extending all the way to the iliac bifurcation. Now I just want to show you a couple of slides that I think will be the future. We did talk a little bit about AI. Thoracic stent graft, again, dissections are not degenerative aneurysms. So it's not the pressure on the false lumen that actually causes it to enlarge. And I'm not going to go through the details of the study for the sake of time, but we looked at peak velocity and shear stress. And what we found in our study that peak velocity and shear stress are actually much more predictive of false lumen enlargement. And I think given time, as AI develops more and more, we'll be able to predict more accurately which of these patients need a stent graft in the acute phase, where you're much more likely to get an adequate seal and elimination of the false lumen. So in conclusion, for acute type B dissections, we usually use a short segment coverage that removes the false lumen at 90%. For chronic dissections, I start by extending from the left common carotid to the SMA. Again, 90% of the people, that's enough. If you continue to have a visceral segment enlargement, I do an SMA and birenal fenestration, extend it all the way to the iliac bifurcation. Thank you very much.